This is Connor Meadows going over the Shockable cardiac arrest protocol for the paramedic protocol. If you arrive on scene and you find a patient that is in cardiac arrest, you're going to perform the initial assessment that starts with the airway, breathing, and circulation. And at that point, you'll determine that the patient is in cardiac arrest. That's when you will begin performing high-quality CPR, which is 100 to 120 chest compressions per minute, a depth of ideally 2 inches, and also you're going to establish an airway and provide oxygen to keep the oxygen saturation at 94%, and you're going to monitor the patient's heart rhythm and blood pressure. The blood pressure is usually more difficult, and that usually doesn't happen as much in the field. If the patient is in VTAP or pulseless VFib, then that's when you realize it is, in fact, a shockable rhythm. You're going to apply the defibrillator pads and shock the patient with 100 to 200 joules on a biphasic defibrillator or 360 joules on a monophasic defibrillator. Once you clear and defibrillate, you're going to immediately go right back into 2 minutes of high quality CPR. You're going to also at that point have your fellow coworkers get a IV established or an IO, and also you're going to be intubating the patient at this time. After 2 minutes of the CPR, you're going to do a rhythm check. If the monitor shows that you are now in asystole or PEA, you're going to move to a different algorithm. Those are not shockable rhythms. Otherwise, if the patient remains in pulseless VTAC or VFib, then you're going to continue with the defibrillations. Also, you're going to start as soon as possible once the cardiac arrest starts, and as soon as you have your IVO established, you're going to get your epinephrine on board. You're going to be giving 1 milligram of epinephrine every 3 to 5 minutes for the duration, as long as the patient remains pulseless. Again, after 2 minutes of that, if needed, you're going to administer you're going to clear and you're going to do another defibrillation. At this point, you want to consider amiodarone, 300 milligram IV push. This can also be repeated. This can also be repeated again with another 150 milligrams push. If the patient were to convert out of the rhythm after the initial amiodarone 300, you can put them on a amiodarone drip over 10 minutes, 150 milligrams. And then after that, you're going to do another 2 minutes of CPR, another rhythm check if needed. If the patient's still if they have not converted out of it into like PEA or systole, then you're going to clear and defibrillate again. If the patient does return, if you do get return of ROSC on the patient, then you're going to move to a different algorithm. That's going to be the post-cardiac arrest care algorithm. But ultimately, as always, the big thing is you're trying to remember to be going over the H's and T's. You're going to be going over your hypovolemia, hypoxia, hydrogen ion, hyperkalemia, hypothermia, your tension, pneumothorax, cardiac tamponade, toxins, thrombosis, pulmonary thrombosis, coronary thrombosis. So your H's and T's, your high quality CPR, making sure that you have just dotted your I's and crossed your T's on your cardiac arrest. That's pretty much it, though. Thank you.